a little bit about trauma-informed care, how to do seeking safety, and also a basic what a community practice could like. It's something that we're trying to start with seeking safety as a therapy. I'm not going to be going over the evidence for this treatment, and that's where I usually go to the website for that, where they have all of these papers. But just like I said in the beginning in terms of disclosures, people that do research in this field are usually quite passionate about it as well. At the same time, I'm not sure what else to do with these patients that are coming through the door to see me. For trauma, I'm just going to talk a little bit about the St. Michael's Hospital strategy, limits to PTSD diagnosis, the ACE study, and talk a little bit about Bessel van der Kolk and developmental trauma disorder as well. For the St. Michael's Hospital strategy, all of you may not be able to see, but there's 3 big boxes that I'd like to point out. One involves advanced system of care for disadvantaged patients and excelling in the care of critically ill patients. And working with patients at Casey House and through the HIV network, you are seeing these patients. And what's slowly coming up in terms of the research that's being done is a lot of these people have early childhood experiences that really shape how they interact with the system. They have early trauma that's sometimes not even up there, not even labeled. You don't find out until you develop that trust over the years. And these are the people that are using the healthcare dollars. These are the people that are the sickest of the sick. And I guess I'm going to sort of argue that without having an approach to treat and manage these patients, it's going to be impossible to provide these goals unless you bring in a trauma-informed practice in some way. For PTSD, it is in the DSM-5, and the full criteria is there for everyone to see. The big limitation with it has to do with what the main stressor is. So in order to get a diagnosis of PTSD, you have to have some kind of stressor where you've observed or perceived some kind of stress to yourself or to someone around you that you're seeing. The other people that are labeled as well are people like us who work with patients. So when you're a care provider, paramedic, firefighter, and you're seeing repeated trauma, you could also meet that diagnosis that way as well. It can affect people's behavior in terms of avoidance behavior. You can have negative beliefs around mood, difficulty with emotions. The thing that's not covered in the DSM-5 diagnosis for PTSD is how this early childhood trauma plays out. It's not even mentioned in there at all. People can have dissociative symptoms, you can have delayed expression, and you also need to see a functional impact on it. And you need the symptoms to last over a month for that to happen. When you've had repeated exposures early on in life, it can lead to this complex trauma type picture. And when I was training, it was more of a research criteria. I'm not sure if it still is a research or if it's officially in the DSM-5 yet. I was reading this book by Bessel van der Kolk about how the body keeps the score. And it was a very, very powerful book. He's a scientist and psychiatrist in Boston. And he's very passionate about what he does. He gives very powerful talks. If you ever have the time to YouTube him and hear him speak, it's very moving to hear him. He talks about his foray into psychopharmacology, what worked, what didn't work. He talked about different patients that he's seen, different treatments that were available. And the thing that was very clear was that the body keeps a score. Even if, in your day-to-day life, you're not remembering the events, those events aren't there, the body does respond to it. And so he talks a lot about how even if we're not having those nightmares, flashbacks from early things that happened, it can shape how we interact with the world. When someone's had early trauma, logically they may know what the difference is, say, between a burning steak and a burning house. Their body doesn't. And so even though they can tell themselves that, oh, this is just a small event, all of a sudden their pulse goes up, their heart rate goes up, and they're having all those symptoms. And when you see them in clinic, they may be screaming, they may be yelling, they may be swearing. And the stressor is something we can't even comprehend. Well, everybody has to wait 5 minutes to be seen, right? It is common for the doctor to be late. We have to change appointments all the time. And you're there in front of them and seeing somebody who's yelling and screaming in front of you. So the other thing that was really powerful about this book is that there was all these evidence-based treatments that were discussed that I hadn't even learned about or been trained in, and I was trained as a psychiatrist. They talked a bit about EMDR, eye movement desensitization. They talked about yoga and the mind and body. They talked about theater and the arts. They talked about integrated family therapy. And there were several other therapies that are available in different places. And you also talked about the struggle in terms of getting this disorder into the DSM-5. He talked about how they prepared research reports, they had national organizations on board, and the response that they got from the American Psychiatric Association was this is merely anecdotal evidence, and there's not enough evidence that this exists. And I would argue that a lot of the patients that you end up seeing with HIV have symptoms related to this. The ACE study was something that was done by Kaiser Permanente in California. And this was a study where they looked at early childhood experience or adverse childhood experiences. And this is something where there was a very powerful TED talk by Nadine Burke-Harris, where a pediatrician, where she actually talks about this and the long-term medical impacts. And while we would suspect that, say, depression and anxiety were related to it, things like lung cancer, things like heart disease were also increased in people that had these early childhood experiences. And this is something also to keep in the back of the mind. So even though right now trauma may not be at the forefront in terms of how we approach and handle patients and clients coming through our door, in some organizations it already is, we're not going to be able to stop this push, and this is going to be eventually part of training because the evidence is there. For trauma-informed care, I just wanted to basically just have a simple line on it. And basically with trauma-informed care, all it really is shifting the question from what's wrong with you. For example, when a patient's yelling at us, screaming at us, they're responding in a way that doesn't make sense given the environment that they're in, to what's happened to you, and how does that continue to live on in your life and your daily experience. And the hope is that over time we develop this greater sensitivity and deeper understanding of what that patient experience is. It doesn't necessarily mean that you talk about it at every session, but just having that awareness as well. In terms of normal development, you can reliably perceive how the world is. You can plan the future in a flexible way. You're able to recognize your feelings, tolerate them long enough to learn from them. Develop a stable sense of identity and self-efficacy. You can form trusting relationships. Someone brought up trust earlier, being a big challenge. And all of these depend on having a strong connection from the emotional brain to the logical brain, and all of these depend on having those early childhood experiences that can make an impact. And when you're exposed to trauma, there's three main things that happen. So the emotional brain becomes a survival brain. So what that happens, you're always on guard, you're always prepared, you're always hypervigilant, regardless of what's happening. We see this in our soldiers that come back from war, where they can't sleep at night. Everything's quiet, everything's calm, all of a sudden they're hyper-aroused. In fact, it's only when there's high stress, high things around them, that they can actually sort of calm down. Your alarm system's distorted. So that whole thing that I talked about, the burning state versus the burning house, your body and mind respond the same way when you've had that early trauma. And you're also unable to fully appraise the present and then learn from experience. So you see that same pattern happening over and over again. Like the example that one of our colleagues talked about with the planning thing. You meet with them, you plan, they come up with something, the same thing happens again completely. And this trauma picture provides a very good explanation for it. And I want to pose a question to the group that do we think that these difficult to engage patients need to fully work through their trauma before we can help them? So many patients don't see the connection between their symptoms and their history. They'll come to you, well, no, like, why would they make me wait that half an hour for that appointment? Why would I go there and then not have an appointment for me? They don't see that their body's responding to that alarm system partially because of their old experiences. And hopefully, eventually, over time, we can help them see that there is a relationship and then learn how to act in a way that meets their best long-term goals. But absolutely, they don't see that connection. And the same thing happens with somatic symptoms as well. So what Seeking Safety is, I have the website up there, and that covers all the information in terms of where to go to for trainings. It covers some of the basic handouts. It has books, charts, tables that you can buy and see. The thing to remember about it is that it's a present-focused therapy to help clients attain safety from PTSD. When you think of trauma treatment, there's 3 stages to it. At least that's what some experts talk about. The first step is safety. The second step is mourning. And the third step is recovery or reconnection with our environment. With this therapy here, it's all about safety. We don't even necessarily talk about the trauma. I mean, sometimes it does come up. The one thing that we do emphasize is the way that they're responding to the world is shaped by some of their early experiences. And we want to help them create that safety in the world we're here now. There's 25 topics that fit in about 5 categories. interpersonal, cognitive, behavioral, and other. And there's a very, very heavy case management component. So for a lot of you that are working with clients playing that case manager role, this is something that would fit extremely well into it. The main thing is we want to focus on safety. It's integrated treatment, so that means we're dealing with both the substance use. We're dealing with both the substance use and the trauma concurrently. We're not saying we're just focusing on this or we're just focusing on the trauma. 4 content areas, and we spend a lot of time being attuned to the clinical processes as well. The trauma details are not a part of the group therapy. We do want to identify some meaning for the substance use in context of the PTSD. Of course, with nightmares or flashbacks like that, who wouldn't want to drink in some way? Or it's so hard for you to cope with that without the substances. Something where there's some function or purpose to their use. We want to find a way to keep that optimism there. We want to be that guide where we help them get more treatments in the other areas that they need. And we use the harm reduction model or abstinence, depending on the patient, depending on the group that's there. 12 steps always encouraged. You definitely want to empower the clients, and you want to make the treatment engaging and emphasize the core concepts related to it. In order to do seeking safety, all you really need is the book. Read it first couple of chapters and start doing it with individuals. And they've actually studied this with the group in Boston with Lisa Najovitz. So they've done studies where they have, say, workers that have no secondary school training. They've done it with peers. So peers are able to do this training, and it is showing some efficacy. They've done it on the street, so homeless people on the street, in shelters, all these different environments. And their goal was to create this therapy that everyone can have access to. It's not the full treatment for trauma. There's so much involved in trauma work, as if any of you ever read or see the stuff with Bessel van der Kolk, there's tons of treatments that can help these people. This is that starting point, so they can feel safe when they come and see you. They can start to build trusting relationships slowly and build those skills. The way that they suggest that you learn it when you go to the training, to get the book, read 1 or 2 chapters, pick a topic in it. It could be something as simple as asking for help, like the one I handed out. The one I handed out is probably the simplest one that there is there. And then you want to basically coach the patient-client following that format. And the format's extremely simple. The topics include safety, respecting yourself, compassion, use coping, not substances, to escape pain, make the present and future better, learn to trust, taking good care of your body, and never, 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 never give up. There's 25 in total. Every time you start the session, there's five check-in questions. So since our last session, how are you feeling? You don't actually go into in detail, you just sort of hear them talk about how they're feeling, and if it's a group, you just have it go in the group environment. What are some good coping that you've done in the past week? The other thing is any substance use or unsafe behavior. And you want to link that a little bit to the PTSD either there or later on. You want to see if they've completed their commitment. So every session at the checkout, there's a commitment phase as well. And then you ask about community resources. And you can see the way that it was designed. It was actually designed for case managers, community workers, to help people connect to the resources that they need. The next part, there'll be a quote. So the quote can be something like, "No feeling is final." Or if you look through that asking for help handout, on the 3rd or 4th page, there's one page with a quote. You read that quote, and then you ask the group, what's the meaning of that for you? And then you'll have either the individual say that, oh, this applies to me, it doesn't apply to me. You'll have that back and forth, you'll hear that, and then you link that to the teaching in the session. There's opportunities to role play. You really want to link it to the check-in. So all the stuff they talked about during that week, you link it to that specific skill that you're going to be talking about in that session. Give them a chance to practice the skills when they're there with you. And remember, this can be done in individual or in group. And based on the studies that Inhabit's group has done, it's shown efficacy in both. One thing that's heavily involved with it is grounding. So they do a lot of grounding exercises. It's done in crisis situations. Say if a patient may be dissociating or they may be in crisis in front of you. It can be done for a sort of regular emotional piece. And you're bringing them to the here and the present. Some of the comments that were brought up was they're here in this room. The hand, so like some touch of some kind. Obviously for some patients you have to use your discretion for it. But it's very different than mindfulness and relaxation. And that's something that I've only really picked up in the past year or so. Some people talk about mindfulness not being indicated for PTSD. In my experience, I tend to use it quite regularly. The clear difference is you need to get them to the outside world as opposed to going within. So instead of getting them to focus on their breathing, focus inside, focus on the body sensations, eventually they'll be able to do that, but you want to get them to go outside as much as possible. And there's 3 areas that you can ground, and you covered them as you were chatting: mental, physical, and also a little bit of the self-soothing with that safe place. And I want you to think about an emotional experience you had that was maybe somewhat uncomfortable in some way, but make sure you stay within a safe place for you. So if it's somewhere that you don't typically go, and think about that negative emotion. If you could label it from, say, 1 to 10, where 10 is the worst that you've sort of felt and 0 is the best. With the grounding, as much as possible, try to be aware of what's around you. If you want to close your eyes, you can, but the more practice that you get with your eyes open, the little bit better. And while you're sitting here, I want you to just look around the room. Just notice the room. And when I ask questions, you can answer them in your mind. So what color would the walls be? How many windows do you see in the room? Have a look at the ground, and what color is it? What material does it look like? Are there any posters or signs in the room at all that you can see? Describe them. Good. Have a look out the window. Think about what the weather is like right now. What does it look like? Are there any structures or items out there as well? Think about different categories of something. Think about maybe celebrities, different categories of celebrities that may be there. The different names of different celebrities. Think about cities. What are some different cities that are around? Notice the chair underneath you. And feel your feet on the ground. You can wiggle your toes a little bit. Squeeze your hands. Push your hands together. If you can feel the chair underneath you, think about the temperature. You can hold the chair, grip on it. Just feel cold, feel warm. Notice the material, the texture. And now I want you to think about a safe place in some way, a place that you find safe. It can be somewhere you know, somewhere you want to go, somewhere you've been before. Describe it. What does it look like? What's around? Think about a favorite person, someone you know, a favorite song. Think about the melody, the lyrics. And when you're ready, just come back to the room, gently. So the comment had to do with distraction, separating from the emotion, and connecting to the environment around you. And that's exactly what the goal is with that. It's something where different patients are going to have different favorites. They may like the mental grounding, they may like the physical, they may like the soothing. And you want them to come up with their own grounding formula eventually in terms of what works. And for me, I couldn't actually find that sheet that I was looking for, so I was just sort of anxious the whole time. So I was stuck in the emotional piece the whole time. But when we're doing the sessions with different facilitators, we'll rotate who does the grounding strategy and all that stuff as well. This is very different than relaxation for all of you. And for all of our patients that we're seeing where that crisis is common, this is a simple skill that could potentially make a big impact. There's 25 different handouts like this. The group that we started doing is only 6 weeks, and we're rotating the 6 weeks. We only have about 4 or 5 people there right now, and if we get enough, then we'll add a 20-week one for the people that have gone through the initial part. Typically, when groups like this are run by colleagues of mine, they'll start with about 15, and they end up with about 4 at the end of it. And so we want to find a way that we can pick up on that engagement to get people to come regularly. They have studied this, and typically what they find is that when you have a new therapist doing a group like this, the patients get comfortable within like 2 sessions in terms of the format and the structure. The therapist or counselor, usually about 3 or 4, they start to get comfortable with the structure and the process in doing their practice. And the way that I started doing it was I got the book and I started just doing it individually with patients of mine that had some trauma, had some addiction issues, just in terms of skills that I thought might be relevant for them in the here and now. Some of them really responded to it, like the structure, like the handouts. A couple of them, it wasn't a good fit. It is something, though, that I think that any one of us can offer, especially given all the complexity that all of you deal with on a regular basis. One thing that came up was that people were chatting about some of the clients that they see and some of the challenges that come up in their sort of day-to-day work. And for me, I know I always find that helpful, hearing how 3-4 of my colleagues would approach the same patient. If you do end up starting this, there would be value in seeing if there's anyone else that you work with that also is doing that, maybe work together to figure out what that best formula would be. And I know for the way that we've run it, there's a colleague of mine, Chris Lopez, at the Detox. We're doing it together, learning it together. Our goal is to eventually have individual separate groups that we're running. So basically, I wanted you to know about trauma, how it affects people's lives. A lot of you are aware of it. I wanted to talk a little bit about what seeking safety is. I didn't review the evidence. A lot of that's available on the website that they have. And I wanted to give you a handout for something that you could potentially use with a client that you see in front of you. If any of you are interested in learning more about seeking safety and working with myself or a group of people, there's a handout that has information about a community of practice that we're starting. All of you are welcome to come or pass it on to anyone else who you think you might be. The thing that's been most helpful for me working in addiction is having colleagues that I can talk to about the challenging patients, hear about their specific approaches, and then figure out what's the best approach for the person in front of me. It's something that I find has been very difficult when I work in isolation with some of these complex cases.